دكتور نبدأ؟
تفضلي يا بابا تفضلي.
السلام عليكم، صوتي واضح؟
واضح.
أيوة واضح.
السلام عليكم ورحمة الله وبركاته. Hi everyone, my name is Raghad Al-Watfan, and today inshallah with my colleague Rana Sam'ani we will talk about the salivary gland. So this is our objective today, to talk about the surgical anatomy of salivary gland, to talk about presentations, pathology and investigations used for diagnosis of salivary gland, and also we'll talk about the medical approach for treatment of stone and some example of infections and tumor that affect salivary gland. Before I start talking about the anatomy of salivary gland, I think guys this is a last chance for you that someone explain to you the anatomy one by one. So if you have questions, just ask, and I like discussions يعني. So let's start the anatomy of parotid gland. So we have actually a major and minor salivary gland. And our discussion today inshallah about the major salivary gland, الباروتيد والسبمندبلر والسبلينجولار gland. طبعا عندنا minor salivary gland اللي هي اللابايل gland والبكال gland, البالاتيل gland واللينجولا gland. So before I talk about the parotid gland, there is actually important nerve that run within the gland. Do you know it, guys?
Facial nerve.
Facial
Yes,
nerve.
excellent. So the parotid gland actually it's the largest salivary gland, تمام? It's wedge-shaped gland and line within the parotid region. طب إيش أهمية parotid region اللي تعرفينها؟ يعني assume that you are sitting in ER and patient come to you and explain there is a pain, and if you know the parotid region exactly, you will predict one of the differential diagnoses that patients may have infections in parotid gland. طبعا as I explained before, divided by facial nerve into two groups, superficial and deep. So regarding the parotid region, there is actually a picture explain the parotid region very well. So this is the parotid gland and this is the duct. Superiorly عندنا الزيجوماتيك arch as you can see. Inferiorly عندنا lower part of the mandible. الانتيريلي راح يكون عندنا المسيتر، والبوستيريلي راح يكون عندنا ستيرنوكلينوماستويد. طيب إيش هذه العضلة اللي هي الباكسينيتر؟ الباكسينيتر أهميتها إن الباروتيد duct run within masseter and pierces الباكسينيتر to open into upper second molar tooth. So it's important landmark. As I explained earlier, the parotid duct is 5 cm long, exit from the anterior border of a gland, run over the masseter muscles, then pierces the buccinator muscles حتى تفتح على open opposite the upper second molar tooth. Regarding the structures, there is 3 important structures that run within the gland itself. You must memorize it. اللي هي facial nerve وزي ما قلنا قبل والريترومانديبولار vein والاكسترنال carotid artery. طبعا بالطبع أي nerve أي blood supply that run within or near the gland it's give its supply سواء السنسوري سواء الموتر أو even سواء السكرتري والسنسوري or even the blood supply. So أكيد راح يكون vascular supply اللي هو structure that run within the gland, external carotid artery والretromandibular vein. Regarding the lymphatic drainage عندنا parotid lymph node اللي هي superficial with deep that run drain طبعا to the deep cervical lymph node. So let's talk now about the nerve supply of parotid gland. خلونا نخلص من السمباثيك. طبعا دائما السمباثيك هي plexus around the major blood vessels around that structure. So أكيد راح يكون عندنا important يعني artery محترم اللي هو external carotid artery. There is a plexus around it which is give a sympathetic supply. Regarding a sensory, we have auriculotemporal nerve greater auricular nerve auriculotemporal اللي هو branch من trigeminal nerve اللي هو branch من mandibular nerve. The parasympathetic, actually, I would like to explain it in a picture. It would be more easy. All started with inferior salivatory nucleus زين اللي يطلع من المظلة بلونكاتا. هذا المظلة وهذا البون وهذا الميدبرين. So النيوكليوس الانفيريور salivatory nucleus راح تطلع منها الجلوسوفارنجيال نيرف اللي هو النيرف التاسع. راح يطلع من السكال through الجاجلر foramen. لكن part of it will re-enter the skull تمام through tympanic caniculi which is through a branch called tympanic branch. A tympanic branch will form a plexus called tympanic plexus. Before I proceed explanation أنا الآن التمبانيك branch والتمبانيك plexus وين بالضبط داخل السكال؟ Do you know؟ يعني remember if you remember an ENT there is picture اللي هو tympanic plexus around structures. Okay, maybe you forget it. Actually, tympanic branch with tympanic plexus, we are here in the middle ear. There is a promontory, if you remember the promontory, and if you remember the picture of middle ear. So glossopharyngeal nerve ويطلع من السكال through jugular foramen, لكن part of it will re-enter the skull. You must يعني memorize that course. Re-enter the skull through tympanic caniculi يعطينا tympanic branch والtympanic plexus. التمبانيك بلكسس راح يعطينا برانش called lesser petrosal nerve. lesser petrosal nerve طبعا الآن راح يطلع من السكال through foramen oval مع المانديبولار nerve. بعدين راح will be rely in ganglia. It's important ganglia. You must memorize it. You must say where is located, which is called otic ganglia. تمام. بعدين عندنا post ganglionic parasympathetic fiber that's carried by بمساعدة مين؟ الإيوريكولوتمبورال نيرف. أكيد اللي طلع معه من الفورامين أوفال اللي هو المانديبولار نيرف. Then we have the secretory fiber. So it's very simple. If you remember the course, it will be very easy. All started لما الجلوسوفارنجيال نيرف يطلع من السكال، بعدين re-entering the skull. أنا الآن بالميدل إير، بعدين طلعنا من الفورامين أوفال، بعدين سوينا relay in otic ganglia. Clear?
clear.
Okay, thank you. So this is the parasympathetic pathway. طبعا another diagram if you يعني some of you like maybe draw and some of you like يعني word. For me really I like this diagram. So this is the anatomy of parasitic gland. I hope it's clear. It's very easy. Just trick اللي هي parasympathetic supply. برضو إذا قريتها أكثر مرة راح تستوعبينها. Regarding the anatomy of submandibular gland طبعا submandibular site in digastric triangle. زي ما قلنا parotid gland there is important structure اللي هو الفيشيال نيرف، لكن هنا submandibular gland divided by المايلوهايويد muscles. زي ما تشوفون هذه المايلوهايويد muscles اللي هي الفلور of the mouth، تمام، divided the gland into superficial والdeep part. The submandibular duct about 5 cm long، تمام، وتطلع من الdeep part of the gland والduct open in the floor of the mouth at sublingual papillae. So this is the submandibular duct. What about the submandibular duct? هل في important relation? Yeah, there is a lingular nerve. A lingular nerve hook around the duct. As you can see, this is the lingular nerve. Hook around the duct from lateral to the medial. طبعا زي ما قلت لكم any nerve, any blood supply around the gland راح يكون part of its supply. So let's say the arterial supply والvenous drainage والlymphatic drainage. الارتيريال supply as you can see just بنوضح الرسمة، هذا الاكسترنال carotid artery وهذا الفيشيال artery، تمام، هذا الاكسترنال وهذا الفيشيال artery وهذا الفيشيال vein. So الارتيريال supply راح ياخذ من الفيشيال artery والvenous drainage راح ياخذ من الكومن فيشيال artery واللينجولا vein. أما الليمفاتيك drainage راح تاخذ من submandibular lymph node that drain into a deep cervical lymph node. This is the arterial supply and venous drainage. What about nerve supply? Actually nerve supply is very easy, more easy than parotid. Sensory fiber أكيد من lingular nerve which is hook around the duct by itself. الsympathetic زي ما قلنا plexus around the major blood vessels اللي هو الفيشيال artery by itself. الباراسمباثيك راح يطلع من السوبيريور salivatory nucleus. الباراسيت راح يطلع من الانفيريور salivatory nucleus اللي هو يقع في البون through الفيشيال artery. الفيشيال nerve. الفيشيال nerve give a branch called chorda tympani. The chorda tympani join important nerve called a lingular nerve at 45 degrees. That joining will be relayed in submandibular ganglia, which give both ganglionic parasympathetic supply. So it's very simply bifacial nerve. لكن عندنا nerve that's joined around 45 degrees اللي هي called a lingular nerve. Clear the submandibular gland?
Clear. Yes.
Okay, thank you. Regarding the sublingular, okay. Regarding the sublingular gland طبعا it's more easy because actual physical supply والnerve supply والlymphatic كله نفس السبمندبلر duct، بس اعرفي وين تقع بالضبط. السبلينجولا gland هي almond shape تقع بالسبلينجولا fossa. This is the sublingular fossa. تمام، كأنها أرفع من submandibular duct. sorry, submandibular gland. Regarding the sublingular duct إحنا عندنا من 8 to 20 duct open into the floor of the mouth called the sublingular fold. And if you remember this picture from GIT course, which is the lingular vein والduct اللي هي regarding the gland itself. And this is pictures for sublingular gland. زي ما قلنا إن arterial supply similar to submandibular gland. So we have the fascial artery by arterial supply, والvenous drainage common fascia, والlingular vein, والlymphatic through submandibular lymph node that drain into deep cervical lymph node. So that's it regarding the anatomy. Any question?
No, everything clear.
Thank you. So I will ask you, and if you don't answer, I will kill you. Okay, and the doctor إن شاء الله حاضر معنا وشاهد. الباروتيد duct open
يعني
opposite to.
كده على طول كده على طول كده عشان السليفري جلاند.
Okay, الباروتيد duct open opposite to.
Second molar teeth.
أحسنتي. طيب, I explained that there is important nerve that's associated with submandibular duct. Okay,
Lingual.
طيب السايت of sublingular gland there is foci described in mandible اللي هو نفس name of the gland.
Sublingual.
أيوة أحسنتي بارك الله فيك, اللي هي sublingular fossa. Now I will talk about the pathology of salivary gland. ما راح أطول عليها, بس إنه إحنا تقريبا عندنا 3 main category ممكن إن نفصل فيها السليفري gland. عندنا neoplastic, any part of the body have neoplastic probability, and also we have inflammatory, and we have cylindrosis اللي هو non-neoplastic enlargement of the salivary gland. So salivary gland ممكن يجي هذول disease أو pathology either neoplastic or inflammatory or enlargement. Regarding the presentations of salivary gland, طبعا assume that you are sitting in ER or you are a doctor and sitting in your office and a patient come to you, explain that I have, for example, painful lump under the tongue. How you exclude or how you occlude that one of the differential diagnoses may disease in parotid gland or disease in salivary gland by itself. ممكن يكون البيشنت عنده painful lump either under the tongue ولا around the cheek or under your chin, increase with eating. ممكن يكون عندنا البص that drain into the mouth. أكيد راح يكون عندنا TMJ pain. برضو راح يكون عندنا الفيفر ممكن as any inflammatory state. Okay, that's it regarding my objective. I hope it's clear and thank you. Rana, inshallah, will continue the rest of the presentations.
أحسنت يا
Thank you,
بنتي.
Rana.
أحسنت يا رغد، ربنا يسعدك يا بنتي يا رب. والحمد لله اللي ربنا نجى بنتي الغالية برضو من الذبح والقتل، الحمد لله برضو أحسنت. تفضلي يا رنا، ربنا يبارك فيك يا بابا، تفضلي.
Okay, thank you, Ragad. Okay, I am Rena, and today we are going to talk about infection, stone, and tumor of the salivary gland. Next slide, please. Okay, now let's start with the salivary gland infection. They are divided into 2 groups, acute or chronic. For the acute, which is usually and most commonly caused by Staph aureus. And I want to ask you, anyone here know bacteria can cause acute infection other than Staph aureus?
Streptococcus.
Yes?
And E. coli.
Yes, excellent. And for the chronic, when there is obstruction of the duct, and this obstruction will lead to chronic. This is due to stone or stricture. Please, second slide. Okay, and now let's move to the diagnosis. For the diagnosis, we can diagnose it clinically, or increased serum amylase usually indicates parotid involvement. Culture of the discharge is very useful, and we can use ultrasound or CT if the abscess is suspected. Second slide, please. Okay, now let's move to the treatment. For the treatment, it depends. If we treat acute infection, we can use antibiotics, gland massage, hydration, or any drug or substance that increase the flow rate of the saliva. Also, our oral hygiene is very useful. Okay, now let's move to the chronic infection. For chronic infection, we can treat it conservative, like hydration, gland massage, or we can do surgery like cystoscopy or open surgery. Next slide. Okay. Okay, now let's move to salivary stones. Next, please. Okay. Okay, the salivary stone is caused by the formation of stone in the duct system, and this is mainly affect the submandibular gland. And I want to ask you, anyone here knows what is the component of the salivary gland stone?
Protein and
Yes.
calcium carbonate.
Yes.
Carbonate to solids.
Yeah, excellent. Thank you. Thank you. Excellent. Exactly. Next slide. Okay, now let's move to the diagnosis. As you can see in the second picture, we can see CT non-contrast, which is very accurate in detecting the stone. Also, we can use ultrasonography. It is very useful for the diagnosis of the stone of salivary gland. Next slide, please. Okay, now let's move to the treatment. First of all, we should treat the acute infection, and this is the first step. And the second step is the surgical removal of stone, which actually depends on the location. For example, submandibular stone that can be palpated and are located in the anterior floor of the mouth, we can do excision intraorally. But submandibular stone near the helium require excision of the gland. And this is for the submandibular gland. But for the parotid gland, it is unfortunately this is very difficult, and this may require parotidectomy. Okay, next slide, please. Okay, cystoscopy. Okay, I want to ask you, what do you think? What's the better, open surgery or cystoscopy using endoscope?
Endoscopy.
Cystoscopy.
And why?
Less
Because,
preservation of the glands.
Yes, excellent. Yes. Yes, it is
invasive
superior in stone clearance and symptom resolution and gland preservation. Thank you, everyone. Which is a procedure when we insert a semi-rigid endoscope into the salivary duct, and thus allowing us to remove the stone. Next slide. I have video for you in the end of the seminar for the cystoscopy.
تبغينا نبدأ الحين؟
اوكي. لا، خلي اخر شيء احسن. ولا تبغانا الحين؟ ترى عادي عندي.
آخر شيء أفضل.
خلاص. Okay. Now let's move to the salivary gland tumor. Okay, most of the salivary gland tumor are painless and benign and gradual onset. For the initial and the specific investigation, we should use ultrasound with fine needle aspiration with or without true cut biopsy. CT and MRI images are both very useful. This is for the initial and the specific, but also we can use routine investigation like vital signs, CBC, liver function tests. As you can see in the table, you can see that the parotid gland, it is the most common, and thank God it's associated with the less malignant, 10 to 20%. But submandibular and sublingual, They are very uncommon, but they are unfortunately associated with the high rate of malignancy. So that parotid gland associated with benign, and submandibular and sublingual associated with malignant. Next slide. Okay, now let's start with the benign tumor, which is polymorphic adenoma, which is the commonest type and the very good prognosis. It is located where? It's located in the superior lobe, mostly in the tail of the parotid gland. But here you can see it is the recurrence rate is very high, and that's why we do superficial parodectomy. That's to prevent the recurrence. Okay, next slide. Okay, the second most benign tumor is Wharton tumor, where it is located in the tail of the parotid gland. Smoking here is a risk factor. Can you imagine that it's increased the risk 8 times? For the treatment, surgical excision is the best. Next slide. Okay, now let's move to the malignant tumor. The malignant tumor, mucoepidermoid carcinoma, it's the commonest malignant tumor. 60% arise from the parotid. Adult women are more affected, and usually most of the patients have history of previous therapeutic radiation. The mucoepidermoid carcinoma divided into subgroup: low-grade malignant tumor, painless and slow growing, or high, which is rapidly growing mass, and the treatment depends on the grade. For example, in stage 1 and 2, we treated the white block excision, and 3 and 4 we do radical excision with or without neck dissection, with or without postoperative radiotherapy. Next slide, Ragad. Okay, thank you, Ragad. Adenoid cystic carcinoma is the second most malignant salivary gland, and this is mainly occurs where? In the submandibular and sublingual gland. And unfortunately, this has high affinity for what? For perineural separate. And unfortunately, also it has high affinity to blood separate and can occur, the separate can occur to lungs and bones and liver. So the presentation will be enlarging mass with paresthesia, facial nerve paralysis. And so in the treatment, we do facial nerve sacrifice with local excision. Facial nerve sacrifice, which is a removing of the facial nerve, which is known as radical parotectomy. Also, we treat it as a post-operative radiotherapy. This is for the adenoid cystic carcinoma. And now let's move to the second one, which is the squamous cell carcinoma. Ragad, next.
Yes.
Okay. Okay, lastly, the last malignant tumor, which is the squamous cell carcinoma, which is a rare, and men are more affected. It is highly invasive. So the treatment is complete local excision, neck dissection, and post-operative radiotherapy. I think that's it. And here's our reference. And رغد عادي تشغلي فيديو.
برافو يا رنا، ما شاء الله عليك، ربنا يسعدك يا بنتي، ان شاء الله.
Okay, this is the video for a endoscopy. As you can see, here is the slow rate of the saliva, and this will lead to the infection and the stone formation, mainly the calcium carbonate. There will be infection and swelling of the painful swelling of the gland. Okay, here we insert the semi-rigid endoscope. Okay, thank you. Any question?
Thank you, Rana. It's clear.
شكرا يا رنا، ممتازة يا بابا، ممتازة ما شاء الله عليك. إن شاء الله.
السلام عليكم. واضح صوتي؟
واضح.
Okay. I am Hela Jarbour, and today I'm going to talk about the congenital defects of the face. First of all, my objectives are embryology of the face, lip, and palate, and then going to talk about the etiology, classification of the development abnormalities of the face. After that, going to talk about the importance of the team in the cleft care, and finally, it's talk about the timeline for repair. First of all, orofacial clefting is the most common congenital anomaly, is known to occur 1 to 500 live weight breaths. A clefting of the lip or palate is felt to occur around 8 weeks of the embryogenesis, either by failure of fusion of the medial nasal process and maxillary promonosis, or by failure of the mesodermal migration. It is multi-factors. There are factors: it's increased clefting, parental age and family history, and drug use and infection during pregnancy, and smoking during pregnancy will be all these factors increase clefting. We'll start with embryology, lips and palate. The nose and mouth of the baby developing between 5th and 12th week of the life, and lip and palate originated from 3 areas of the baby development phase. First, we have a central or frontal nasal prognosis. It's normally it grows to become forehead and nose and middle portion of the upper lip and primary palate. And second and third areas, we have right and left maxillary prognosis. It grows and become a lower face and lower lip and middle portion of the upper lip and secondary palate. These 3 areas will be the child developed face. It's grow towards center of the face and fuse together during 6 and 13 weeks of the pregnancy. When this happens correctly, the child lip and mouth and palate is developed normally, but sometimes its growth process is distributed in some way, and this prognosis don't meet together. And when this happens, it's incorrectly will be result in a cleft in lip. Tunicast prognosis are palatine shelf, which is started out as leakage on either side of the mouth. And as the fetus grows, this leakage it is joined in middle to form back of the palatine in some way. And it is starting to up front by teeth and move backward. If this process growth and interrupted in at any stage of the embryology, it will be its gap will be developed and resulting in a cleft either by lip or palate, and it's depend on the process. For etiology of the cranial facial anomalies, there are multiple etiology. We have chromosomal disorders and single gene disorders and infection during pregnancy or use of the medication during pregnancy. And also we have metabolic regimen and radiation exposure. For a classification of the cranial facial anomalies, we have different types. We have unilateral, in first pictures, unilateral, left, incomplete, cleft lip. And in first pictures, in the second line, we have unilateral, cleft, complete cleft lip. That's a meaning in incomplete unilateral cleft lip. That's meaning it's cleft in one side of the upper lip, which doesn't extend to the nose. And the complete unilateral cleft lip, the cleft in one side of the upper lip, which extend to the nose, and nasolabial muscle range are disrupted in one side, resulting in asymmetry, deformity, include external nasal cartilage and anterior maxilla. This deformity will be affected in mucocutaneous tissue and causing displacement of the nasal skin and of the lip. And here we have in first line in second pictures, isolated cleft palate forms 1/3 of the all facial cleft. And in second line, in second pictures, we have bilateral complete cleft lip. That's a meaning incomplete bilateral cleft lip. That's a meaning a cleft in both sides of the upper lip, which it is not extended the nose, and complete bilateral cleft lip in on both sides of the upper extended the nose, and maxillar, muscular and cartilaginous deformity will be affected in the tissues. And in this type, which must be applying for surgery to repair bilateral clefting lip. And in third pictures, we have complete cleft palatine and incomplete cleft palatine. Incomplete cleft palatine, a cleft in back of the mouth, in soft tissue, in soft palatine, and complete cleft palatine. That's a meaning it's a cleft affecting in the hard and soft parts of the palatine, and mouth and nose cavities are exposed to each others. And third types of the cleft palatine, submucosal cleft. That's a meaning it's included in hard or soft palatine. Soft palatine that is covered by membranes lining a roof of the mouth. Do you know about the complications of the cleft lip or cleft palatine? Anyone?
Dental problems sometimes.
Speech
Yeah,
and
exactly.
language problems.
Yeah, thank you. The complications, it include feeding difficulty and ear infection and hearing losses and speech and knowledge delay and dental problems. And for a team, for a team membership for diagnosis and treatment for cleft lip or cleft palatine, we have it's included nurse and general pediatricians and medical geneticists and plastic surgeon and oral surgeon and also speech therapists. First, when this case identified as clinically and physical by the team, have meeting to evaluate the case and discuss the findings and formulate a treatment. Then will be a team will inform the patient family and discuss the options, and maybe it's leaded to the modified as needed. As the case is progressive, it's need meeting depend on progressions of the case. For its time for repair from birth to 6 weeks, it include feeding assessment and supportive from the parents and hearing assessment. From 3 to 6 months, it includes surgery to repair a cleft lip, and from 6 to 12 months, a surgery to repair cleft palatine, palate, and from 3 years to 5 years, it's needed to a speech assessment, and from 8 to 12 years, it's needed to bone graft to a cleft lip. And from 12 to 15 years, it's needed to monitoring jaw and orthodontic treatment. That's it. Thank you. Any question? This is my
Thank you.
reference.
No, thank you.
شكرا يا هيلا. هو انا بس عايز اقول لبناتي الغاليين بس في كومنت صغير. انت قلت من ضمن الكومبليكيشنز يا هيلا انه في سبيتش ديفكت عند بتوع الكليفت بالات. احنا كنا دايما نسأل، عايز حد من بناتي بقى الغاليين كده، هختار كده حاجة كده يعني سبوراديك كده. في فرح العساف معانا؟ فرح العساف معانا ولا مشغلة الموبايل ونايمة؟ كما توقعت. طيب ادي واحدة كمان مش موجودة. مها السويد. مها السويد موجودة؟ مش موجودة. مها موجودة؟ طيب يا مها لو سمحت شغال المايك عشان عايز أسألك سؤال.
أيوة دكتور، عيب فتح المايك قبل شوي، الحين اشتغل.
طيب ما فيش مشكلة يا بابا. عايز أسألك دلوقتي، هيلا قالت لك إن في سبيتش ديفكت عند كليفت بلد، تفتكري ليه؟
أتوقع عشان النوز.
دي واحدة منهم. النوز بقى مالها؟ لأن البلد مفتوح على النوز، صح؟ هيبقى
Yes.
أيوه، برافو عليكي، اكسلنت. ما هيبقى في عندي نزل تون وأنا بتكلم. برافو، دي واحدة من الحاجات. ممتازة. ميار.
تمام يا دكتور.
تفتكري إيه ممكن يكون سبب تاني غير اللي قالته مها يا بابا؟ هو مش اختبار، بس أنا بنكشكوا كده عشان ما تبقوش سرحانين مننا بس.
لا، هو صح إنه يعني اللي واضح إن النوز لأنه مفتوح مع الفم، فعشان كذا أكيد يكون في اللكنة هذه بس.
طيب جميل، ماشي يا بابا. وظائف موجودة؟
موجودة دكتور.
اتفضلي يا ست البنات. تقدري تقولي لي مثلا حاجة تانية غير اللي قالتهم، غير اللي قالوه بناتي النوز؟ هل قدرت توصل لك نقطة تانية من الكومبليكيشنز دي ممكن تأثر معايا؟
على السبيتش يعني؟ لا دكتور، ما عندي فكرة إلا إنه مفتوح على النوز. هذا اللي يعني قالوا لي البنات قالوا لي بقوله.
ممتاز، جميل يا وصايف، شكرا يا بابا. رغد الحميدان معايا؟ طيب رغد الحميدان تقريبا نايمة هي كمان زي فرح العساف. طيب رغد الخضير موجودة؟ ما شاء الله ما شاء الله، ده النوم جامد قوي يوم الخميس. يا اما هم نايمين يا اما راحوا موسم الرياض. ان شاء الله اقابلكم هناك بكره ان شاء الله. اصل انتوا مشكلتكم مشكله البنوتات العسلات دول، مش عارفين دكتور ايمن الجدع والله العظيم. وانا قاعد في بيتنا عارف مين اللي قاعد معايا ومين اللي بيسمع ومين اللي نايم ومين اللي مشغل الموبايل ومديني الطرشه ومين اللي بقى ولا. ودي بصراحه هقول لكم حاجه يا بنات، يعني انا هقول لكم دلوقتي الاول الكوزس دي ليه. اولا انا يعز عليا جدا، وكانوا بناتي واولادي عارفين الكلام ده كويس جدا. انا ممكن تغيبوا عندي او تغيبوا عند اي حد تاني، انا ما عنديش مشكله. لكن يوم السيمينار بتاع زمايلكم اللي تعبانين فيه وعاملينه وبيعملوا له برزنتيشن وما تجيش على الاقل تسمعي لها وتشجعيها وتعملوا سبورت لبعض، دي حاجه وحشه قوي. واسمحوا لي برضو بناتي اقول لكم وما تزعلوش مني، انا ما عداش عليا باتش في ميل من يوم ما جيت القسيم من 15 سنه زي الباتش بتاعك، ولا في غياب كده. ما اعرفش ليه. هل انتوا مش انترستنج في كورس الجراحه ان جنرال، ولا مش انترستنج في ايمن الجدع كسبيشال، ولا الشتاء دخل بتحبوا تناموا، ولا ايه؟ انا ما شفتش بامانه.
لا الدكتور معاك
بالعكس مرة مستمتعين
عشان
معك.
يوم اجازه
احنا
يعني
عددنا اصلا قليل 23.
عددنا قليل حنا.
انا عندي الكشف بتاعكم 23 بنوته، اللي معايا دلوقتي 18 بنوته، منهم انا متاكد 3 4 شغالين الفيديو ومريحين. انا معاكم ان هو يوم الخميس، يوم الخميس بيبقى يوم زهق، والواحد خلاص جاب اخره يعني بعد المجهود بتاع انا ما بقولش لا، بس يعني على الاقل زي ما قلت لكم انتوا حتى مع بعض، يعني مع بعضيكم كده. انا وعلى فكره انا شفت حتى الباتش بتاعكم، الجروب اللي شرفنا يوم السوتشرز. انا عارف ان انتوا جروب هادي خالص يعني، مش شفتكم انا كويس هادين وما. لا عايز اقول لكم حاجه، لازم تو بريزنت يور سيلف. خلي بالك المجتمع دلوقتي وانت بيختارك لما اجي اختار ريزيدنس وكده، عايزين بصي انت دلوقتي هتفايت عشان تاخدي حقك، مش حقك يعني، لكن ما اقصدش حقك حد هياخده منك، لكن الكومبيتيشن بقى عالي يا بنات. الكومبيتيشن بقى عالي. البنوته الكسوفه اللي هتقف ورا هيتاكل حقها. انا عايزك تخش بكتفك، لو في 2 قدامك كتف صغير كده جميل كده وابتسامه رايقه، كتف تقومي نطراهم هما الاثنين ومعديهم وسطيهم، صباح الخير انا موجود اهو، عشان تعرفي تاخدي حقك كويس قوي. اهم حاجه رغد الشخصيه، انا 90% بناتي كويس قوي عارفين الكلام ده اكتر من ولادي كمان. بقول لهم البرزنتيشن بتاعك، انا كان ممكن تنقص المعلومه بتاعتك حته 2 3 وتلاقيني مديك الفول مارك. ليه؟ برزنتيشن هايل. العلم هيتغطى النهارده، بكره بعد بكره غصب عنك هتذاكري وهيجي العلم. احنا مطلوب مننا ناخد علم وناخد معاه، انا عندي البيزك بتاعي اللي يخليني اتكلم بثقه، ده عندي. لكن اللي انا عايز اربيه فيكم خلي بالكم بقى دايما، وده اللي كنت دايما احطه في ولادي وبناتي في السنين اللي فاتت، سيبوكم من العلم جاي واحنا بنديه بفضل الله سبحانه وتعالى، وانا واثق فيكم علميا. بدخل احارب بيكم العفاريت الزر على مستوى العالم مش على مستوى هنا، والله ما بقولها مجامله. انا ليا اولاد وبنات كتير راحوا انترنشيب او كونكشن او كوميونيكيشن بره في اوروبا ورجعوا، ما فيش فرق. المعلومه اللي بنقولها هنا اصل العلم ما بيتغيرش، معاك البيزك شكرا. يبقى المهم عندي البرزنتيشن بتاعك، حضورك. انا مستخبيه ليه؟ خايفه من ايه؟ الحمد لله. انا دايما اقول بناتي هنا متربيين على اعلى مستوى خلقا ودينا، فدي خلاص احنا وثقنا فيه، ما حدش يقدر يمسك. حضورك بقى فين؟ انتوا رايحين فين؟ يبقى لما اجي اختار 3 4 5 في منهم من الرياض وفي منهم من الخبر في منهم من لا انا القسيم انا نمره 1. مش غرور لكن ثقه في نفسي، الحمد لله اتعلمت كويس وعندي حضور. انا لو دكتور حتى ودخلت على المريض بتاعي وانا مهزوز سنه او خايف سنه مش هي والله لو انا احسن دكتور في العالم، هو يعرف الكلام ده منين؟ عايز دخلتي عليه كده تخليها تملي ثقه. لو انا هشخرمه يقول لي انا موافق، انت راجل 100 شكرا. حضورك يا بابا. وانا دايما حتى ادي مثل، انا معايا بضاعه حلوه قوي، يفرق ان انا اخد بضاعتي دي واروح افرش بيها في الخبيب على الرصيف، ويفرق ان اخد بضاعتي دي واروح احطها في الرياض بارك ولا المملكه ولا اي حاجه من الحاجات العاليه اللي هنا، اكيد هتفرق مع انها هي نفس البضاعه. خلي بالكم يا بناتي، انا عايز كده. اوعوا تفتكروا ان انا بزعل ان حد بيغيب من عندي، طب بالعكس، اللي بيجيني بينورني ويشرفني وعلى راسي. انا موجود عشان افيدكم مش عشان ازعل حد. لكن انا بقول لكم انتوا اللي هيحضر هيسمع. حتى انا ولادي يمكن انتوا لسه ما شفتونيش بيت سايد، ولادي معايا والله العظيم اول مره اشوف جروب ولاد على عكسكم تماما. مفيش مخلوق بيغيب، سابقني وقاعدين لي في لدرجه ان في ناس والله بقعد معاهم ل3:30، بنروح قبل واحده ونقعد ل3:30 ومش عايزين نمشي. الحضور وانك تستفيدي بكل كلمه تسمعيها. وانا في البيت سايد تيتشنج، لو مثلا هيله اللي بتعرض دلوقتي كانت قدامي عرضت البرزنتيشن بتاعها، اروح قايل لها وانا قاعد في وسط البتاع كده، ولا يا رهف قولي لي ايه اللي انت شايفاه في الهيستوري بتاعت هيله عايزه تعمل، لان انا متاكد وهيله بتعرض نص اللي قاعدين بيسرحوا. ما هو مش انا اللي بعرض، هي فاكره انها بتعرض قدامي انا بمتحن. لا انا ما بعرضش، انا ما بمتحنش، انا عايز كل اللي قاعد يستفيد. فهتلاقيني وانا قاعد دايما مثلا هيله بتعرض، هتلاقيني ناديت سمر، ناديت فرح، ناديت لينا، لا ناديت كده. ليه؟ عشان الكل يقعد يستفيد ويقعد يخلي باله، مش مني بس، من اي حاجه. حضرتك في مرور مع استشاري ومش انت اللي بتقدمي، خلي ودانك مطرطقه اكتر من اللي بيقدم، عشان اول ما الاستشاري يسال سؤال يلاقيك انت اللي نطه في قفاه. يقوم لما يجي يعمل سيلكشن لحد، اول اسم هينادي عليه اللي كانت على طول معاه، فين فلانه؟ انترستنج وبتحضر وبتسمع وبتشارك. انما انت دلوقتي اللي قايمه غصب عنها وقاعده وتقعد سرحانه وزهقانه ولا او بتلعب في الموبايل، او طبعا مش معقوله حد فيكم بيخش المطبخ اقول دخلت تعمل شاي ولا قهوه، دي مش وارده عندكم دلوقتي. تسلمي لي يا نوره، ربنا يبارك فيك يا بنتي يا رب. انا بقول لكم انا بيسعدني وبتشرف بولادي وبناتي اللي بيرفعوا راسي في كل مكان. دي حاجه فخر لينا كلنا. شوفوا دلوقتي الاستشاريين اللي ماشيين معاكم في الملك فهد وفي بريدة المركزي هتشوفوهم، وما تروحوا الرياضه هتلاقوا ما شاء الله في كل حته هتمشوا هتلاقي الجثمان هناك الله اكبر عليهم. ولادي وبناتي زيكم كده ان شاء الله اشوفكم زيهم واحسن باذن الله تعالى. فما تزعلوش ان انا بنصحكم او بقول لكم حاجه، ربنا يبارك فيكم. وعايزكم زي ما قلت لكم، في فرق بين اني انا بنكسف او شخصيتي هاديه، لا ده مش مكان كسوف، ده مش وقت كسوف. انت دكتوره هتنكسفي من ايه؟ دكتوره لازم تعرضي علمك وتعرضي حضورك، وشخصيتي قويه، انا موجوده، اغلط ما تلخبطي. احنا جايين ليه؟ ما احنا بنتعلم دلوقتي، المفروض ان انا الخبط عشان انا اصلح وانت تستفيدي. اللي هيسمع كلمه دلوقتي هو قالها غلط وانا صلحتها له مش هينساها مدى الحياه، حتى لو اشتغل برانش تاني خالص هيقول ده الراجل ده الله يرحمه من 20 سنه قال لي كذا، مش هتنسوه. انما انا بسمع انا اقول لك برافو شاطره زي الفل، خلاص شكرا. استفدتي ايه؟ استفدتيش حاجه، مجهود عملتيه على فكره كله واخد الفول مارك، هنديله كله. مش تعبتي وعملتي واجهدتي نفسك تستاهلي انك تاخدي الفول مارك. لكن انا عايز الباقي يحترم تعبي ده، يسمعوا، يشجعني. انا كنت سعيد جدا بالبنات وانتم بتبعتوا لزميلاتكم ما شاء الله ممتازه، برافو عليكي، فيري نايس برزنتيشن، هايل. انا ده حاجه هو ده اللي انا عايزكم، انتوا تبقوا في ظهر بعض. ربنا يحميكم يا رب ويحفظكم. اقول لكم بقى حته الصغنطوطه اللي انا كنت بقول عليها ليه السبيتش عمل. اول حاجه ربنا يبارك فيكم حبايبي. اول حاجه زي ما قالت بنوتي بناتي الغاليين ان النوز فعلا النيزل تون ده واحد من الاسباب، فمش هيخلي السبيتش كويس. من ضمن الحاجات الثانيه هيلا قالت لو انتوا لاحظتوا انا عندي هيرنج ريكارنت هيرنج انفكشنز، وبالتالي بيجي لي هيرنج لوس. اللي ما بيسمعش ما بيتكلمش، مش هيتكلم كويس. يبقى اذا الهيرنج لوس هيأثر معايا في السبيتش. في واحده من ضمن الكومبليكيشنز هيلا ما قالتهاش، ما جاتش قدامها في التكست بوك، وانا ما حبيتش اتقل عليها بتكتب عشان ترجع تدور عليها هتاخد منها وقت كبير. انا قلت اقولها لكم. انا في حاجه عندي يا بناتي من ضمن الكومبليكيشنز دي اسمها الفيلو فارنجيال ميكانيزم، واللي مش يفهم حاجه من اللي هقولها يقول لي اعيدها له تاني. فيلو فارنجيال ميكانيزم، فيلو جاي من الفيلس اللي هي السوفت بلت، اخر السوفت بلت اللي هي عند اللهاه بالعربي بتاعتنا دي الفيلس، وفارنجيال جايه من الفارنكس. ففيلو فارنجيال ميكانيزم طول ما انا بتكلم السوفت بلت من ورا بيقعد يخبط في الفارنجيال وول كده، يخبطوا في بعض وانا بتكلم، اللي هو الفيلو فارنجيال ميكانيزم. الفيلاس تخبط فيه السوفت بلد سوري في الفارنكس من ورا. طب وده ايه ده يا دكتور ايمن؟ التخبيطه دي بتقطع الكلمات، بتطلع لك الكلمات اللي انت سامعاها دي. يعني ايه؟ انا الصوت اللي جاي لي من جوه من اللارynx جاي هواء من جوه، والفوكال كورتس بتفتح وتطلع لي الهواء ده. ايه اللي بيقطعه حروف بقى ويبتدي يعمل لي الكلام ده؟ الفيلوفارنجيال ميكانيزم ده، يقطع ويطلع جمل، يقطع ويطلع جمل. طب هل دلوقتي بقى لما هنا قالت لكم انا عندي الكليفت بلد، لو السوفت بلد من ورا مفتوح، هل الفيلوفارنجيال ميكانيزم ده هيبقى مظبوط؟
لا.
اكسلنت، برافو عليكم. وبناء عليه من ضمن الكومبليكيشنز بتاعت الكليفت بلد الفيلوفارنجيال انكومبتنس، مش مظبوطه، وبناء عليه كلماتي طالعه مش مظبوطه. يبقى انا عندي السبيتش ديفكت. انا كنت دايما بحط لهم السؤال ده في الاوسكي، enumerate causes of speech defect in cleft بلد. يهمني قوي ان انت وانت قاعده بقى كده متميزه استفدتي ان انا فهمتي هو الكليفت بلد ده عرفني في ايه في السبيتش. ده فعلا عندي نزل تون مفتوحه، وعندي اير كل شويه فيها اوتايتس ميديا فتحول الى لوس اوف هيرنج. ونمره 3 الفيلوفارنجيال ميكانيزم ده ديفكتيف. عشان كده وانت بتصلحي مهم قوي انك تظبطي الفيلوفارنجيال ميكانيزم، وبناء عليه هيبتدي بعد كده زي ما مها بنتي قالت، هيلا بنتي قالت، اللعب على السبيتش هنبتدي من سن 3 سنين بقى، خلاص الميكانيزم اتصلح، يبتدوا يصلحوا له مخارج الحروف والكلام اللي احنا قلنا عليه. اسف اذا كنت قطعتكم يا بناتي، واتفضلي يا يارا بقى بنتي الغاليه، اتفضلي يا ست الكل، اتفضلي يا ياسمين، اتفضلي يا ياسمين.
دكتور، الفيلوفرنجيال ديفكت تسبب تقطع بالفويس ولا هايبرنازاليتي؟
لا لا لا، السبيتش نفسه هيطلع مش مظبوط، هتقطع الصوت، طالع مش واضح، مش واضح. انت كنتي الصوت بيطلع من جوه صوت ويتقطع علشان يديني كلمات واضحه، انما لما يطلع هتلاقي هوا زي النزل مع نزل تون، فمش واضح اللي طالع ده بيقول ايه.
تمام، واضح.
العفو يا بناتي الغاليين، اتفضلي يا يارا باشا.
شكرا دكتور، الله يخليك لنا.
الله يسعدكم.
So, good evening, I'm Yara Al-Ghazlan, and I will be completing from where Hela left off regarding the congenital defects of the face. My seminar objectives is the key features of preoperative care, perinatal and early childhood management, the principle of reconstruction of cleft lip and palate, and the management of complications associated with the cleft lip and palate. So before we move on to the management, here's a quick introduction. Generally, cleft of the lip and alveolus and hardened soft palates are the most common congenital abnormalities. Regarding the orofacial structures, of course, they can be isolated deformities or associated with other syndromes, particularly these with congenital heart diseases. This is why all children that are born with cleft lip and palate need the throughout pediatric assessment to make sure that they do not have any other congenital heart diseases or any other associated symptoms in case of a syndrome. So sometimes genetic consultation might be where we can do a genetic consultation, but not for all patients, of course. My first objective. So before I move on here, I would just like to summarize the whole seminar in 3 words. So when a patient comes with a cleft lip and palate, we have 3 things to do. First, primary management, reconstruction, and then secondary management. You will see what each of these means as I go through the seminar. Firstly, which is the preoperative care, or we can call it the primary management. So this is for all patient that comes, not necessarily cleft lip and palate. So of course, take history, optimize patient condition, and then choose surgery that offer minimal risk and maximum benefit, and then anticipate and plan for adverse events so we can treat it later, and adequate hydration, nutrition are advised. These are the primary management. So primary management is the feeding and airway. For feeding, most babies that are born with a cleft lip and palate feed well and thrive. And sometimes some of them can be breastfeeded as well, especially if the patient cleft is incomplete and confined to the lip. So an advice that a doctor can give to a parent is that they can use the soft bottles and modified teats like the ones shown here. Sometimes even enlarging the hole in the teeth can help. And then the airways. So in the airways for a newborn baby with a cleft lip and palate, major respiratory obstruction are very uncommon and are seen in babies with Berry-Robin sequence or Berry-Robin syndrome. Berry-Robin syndrome is when there's an underdevelopment of the jaw, so the tongue is displaced backwardly and obstructing the upper airway. This is why they will come with major respiratory obstruction. In this case, there will be hypoxic episodes during sleep and feeding, which are life-threatening and need to be treated immediately. The treatment is retained nasopharyngeal intubation. Some cases you can, in some cases they did surgical adhesion of the tongue to the lower lip. It is done in the first few days after birth, but it is less commonly used than the intubation. Most commonly, it is intermittent airway obstruction, and it is managed by nursing the baby prone. So this is for the primary management. And then we'll come to how, we're still in the primary management, sorry. So according to how old the patient is or how old the baby is, we have perinatal to early childhood management. Prenatal management, when the baby is still inborn, diagnosis should be made. So it should be made or suspected. What type of radiographic imaging do you think we would use in this case for a pregnant lady?
Ultrasound.
Ultrasound.
Thank you. So after diagnosis, we will then talk with the parents and give them the option for either termination of the pregnancy, or best is that we will give them support and that they themselves will be prepared to have a child with special needs. So there are so many risk factors, but I will just mention the maternal risk factors since they are easy to detect. So smoking or alcoholic mother, diabetic mother, any type of diabetes, or when the mother is pregnant when she is above 40, or when she has an iron or a folate deficiency. All of these can result in a baby with a cleft lip or a palate. Then the baby is now born. So how we will manage him? We will manage them by first the airway, breathing, eye protection, and establishing the feeding. So for airway, for the airways, most severe cases, intubation is not possible because of their abnormal anatomy. So tracheostomy is necessarily in this case. But in an emergency, we can nurse the patient, the baby prone, so the tongue will fall forward and opens the airway. In patient or in neonates, even those with not anatomic abnormalities, the effort to breathe is exhausted. So even their ability to feed will be compromised. This is why we will give nasal or orogastric feeding to make sure that nutrition is given. And then when they're in infancy, so the management is the same as neonate, except that we will also have we will also have skull surgery if they have craniosynostosis. So craniosynostosis is when there's a premature fusion of one or more of the skull sutures. This can be isolated or a syndrome, just like left lip and palate. But the problem here is that it will increases the intracranial pressure, and so the patient or the baby will present with episodes of disrupted sleep. Sometimes even with they can be associated even with papilloedema, and if left untreated, it can lead to visual failure. So skull surgery can be a must in some cases. And then when they're in their early childhood, so in early childhood, so the baby is now growing, they start developing a personality of their own, they start interacting with other people outside of their family circle. So sometimes they might have a psychological distress because of how of their appearance. While a surgery is still advised to be delayed as long as possible, but we can still do it in some cases. Early childhood can sometimes even have an airway issues. But an airway issues of an early childhood is difficult to detect or difficult to identify because the parents will think that they are snoring like any baby, when they actually present with the sleep apnea, which present with this insidious onset. In this case, we can diagnose the patient by monitoring his sleep breathing, so we're monitoring while he's sleeping, and we manage him by tonsillectomy, adenectomy, or even distraction of the midface, and many types of ventilators as he sleeps. So we're done now with the primary management. Then we move on to the reconstruction, which is the cleft surgery. So the ultimate goal of a cleft surgery, either cleft lip or palate, is that we will have a patient with a normal appearance of the lip, nose, and face. Speech have to be normal, and dentation and facial growth is within the normal, the range of the normal development. So the principles of the surgery: first, the cleft lip surgery. We will attach and reconstruct the muscles around the oral sphincter. The cleft palate surgery, it is to bring together the mucosa and the muscles with minimal scarring. You will know now, you will see now why we do not want excess scarring in case of a palate surgery. And then two-stage procedure minimizes the dissection. Two-stage procedure, especially in case of
يا يارا
cleft palate. هلا.
يارا نورا بتسألك سؤال ردي عليه.
Wait.
يا نورا اسألي سؤال كتير.
When we can do it. So
I mean the age, like after neonate period or.
So it is depending on if the cleft lip is alone, or if there's the associated cleft palate, or if there's a cleft palate alone. If there's a cleft lip and a cleft palate, and they are unilateral or bilateral, either way, it is two operations, and they are done from 4 to 6 months, the first operation, and then the second month is from 15 to 8 months, so when he's almost 1 year old. While if the cleft lip alone, it is less advanced than the cleft palate, so it is done at 4 to 6 months. While the cleft palate, it is done from 6 months and above. Does that answer it?
Yeah, thank you so much, Yara.
You're welcome. So then the cleft lip surgery. In the cleft lip surgery, we will do skin incisions. These skin incisions are done to displace the tissue, either skin or cartilage, to their normal position, while also giving us access to the retro structures like facial, nasal, and lip musculature. So in this one, which is I'm pointing at, this is a unilateral cleft lip. Incision is made around the lips and the nose, so we can then suture the muscles and the skin and cartilage together. While this is a bilateral, of course, the incision will be larger compared to the unilateral. So you know how the lips is around the lips is the orbicularis oris muscle. The orbicularis oris muscle have two fibers, oblique and horizontal. The oblique, which is most distal, will be sutured to the base of the anterior nasal spine and to the cartilaginous nasal septum, and then we will complete the closure with the horizontal fiber when we suture it. This picture shows both pre-op and post-op of a unilateral and a bilateral cleft palate. You see that the normal appearance of a lips and around it is almost regained. Then cleft palate surgery, which is mostly done as 2 stages, but can be done as one as well. So first we will work with the with the soft palate first. So mobilization and reconstruction of the soft palate, and then we will close the residual hard palate by minimal dissection. Of course, there will be a scar formation, but excess scar formation have a side effect in the growth and development of the maxilla. So they will have, so we will treat them for a craniofacial abnormality, and then they will develop another craniofacial abnormality. Why we do a 2-stage is that because the philosophy of 2-stage closure encourages the physiological narrowing of the hard palate cleft to minimize surgical dissection of the time of the second procedure. Okay, so we're done now with the, We're done now with the primary management, the reconstruction. We come to the secondary management or the management of the complications. So for management of the complication, first we have hearing. While patient with a cleft lip and a cleft palate does not show any increased risk of developing an otitis media, so they have a similar risk as those who does not have a craniofacial abnormalities. But it is said that once we have an otitis media, they will develop a sensorineural hearing loss. This is why assessment must be done. And assessment is done before 12 months of age for both sensorineural and conductive hearing loss by either auditory brainstem response like the one in the picture or a tympanometry. And then a speech, which Dr. Ayman kindly explained. So the initial speech assessment is performed early once the patient starts to speak, and then it is repeated regularly. So of course, if the palate and the lips are affected, so is the teeth. So the dental development, it is very common finding in almost all patients with cleft lip and palate. It has various phenomena. It can be either delayed tooth development or delayed eruption of tooth or any kind of morphological abnormalities. So they should be going under regular dental examination. Then orthodontic.
يا العرض راح.
يا العرض راح.
تمام دقيقة. Okay. The orthodontic management. So many patients with a cleft lip and palate require orthodontic treatment. It is the treatment is commonly carried in 2 phases. First, the mixed dentation, and then the dentation. The mixed dentation is from 8 to 10 years, and it is to expand the maxillary arches to preload the alveolar bone graft. And then dentation, once they are old enough, like in 14 or 18 years, we will align the dentation and then provide a normal functioning occlusion. So that's all. As a summary, the management of children with a cleft lip and palate, it is very complex, requiring the skill of a multidisciplinary team, because it is associated with heterogeneous congenital abnormalities. It is difficult to generalize a protocol for all patients with a cleft lip and palate. This is my reference. Thank you all for attention, and sorry for taking so much of your time.
Thank you, Doc.
Thank you.
Thank you very much.
Thank you so much.
شكرا جزيلا يا يارا، وربنا يبارك فيكم جميعا. جميعا اللي عملوا برزنتيشن النهارده هايلين، واللي حاضرين معايا اكتر من هايلين، واللي ضحكوا علينا ودخلوا باساميهم وراحوا ناموا تاني برضه هايلين. كويس انهم بيستفيدوا، ياكلوا يشوفونا في الحلم على الاقل. يارا بس عايز اقول لك حاجه على فكره، انا بنتي اخر العنقود اللي اتولدت هنا في بريده جسمانيه زيكم اسمها يارا، مسميها يارا ايمن الجدع.
نتشرف والله دكتور.
الله يسعدك يا بنتي، يا رب ربنا يبارك فيك يا رب. نورتوني وشرفتوني النهارده. يا رب ما تكونوش زعلتوا من كلامي اللي انا كنت بنصحكم. والله انا مش ولا على فكره ما حدش يزعل، انا لما بتكلم اللي حاضر هيقول لي انا ذنبي ايه؟ لا